who is joining us for this last section. Dr. Glover has a PhD in molecular biology and immunology from Johns Hopkins, and he completed his postdoctoral fellowship in clinical and public health microbiology at the University of Washington. He is a diplomat of the American Board of Medical Microbiology, and he joined the North Carolina State Public Health Lab in April of 2019 as an assistant laboratory director overseeing the infectious disease section. Dr. Glover serves on a variety of national committees and work groups with external partners and organizations, including the American Society of Microbiology and the American Public Health Laboratories Group and the Clinical Laboratory Improvement Advisory Committee. He's going to be here to help support some of the conversation we're having about diagnostic capacity and public health in the state of North Carolina. Additionally, Dr. Mobley will be joining us, and I have introduced her before. She is, of course, one of our experts here in North Carolina, supporting the state in executing excellence in STI care across the local health departments. One moment, I am still loading up my slides. Lindsay, are there any other housekeeping comments we need to take care of?
No, we are all set housekeeping wise. I do want to thank everybody for being so engaging in the chat. I know that participants aren't able to see what other participants are sharing, but we do appreciate your comments and questions that continuously have been coming in today. We love to see an engaged audience. And thank you, everybody, for your patience with this morning with our technical difficulties. As you heard me say before, technology is great. We love that we're able to offer this to nearly 1,000 people and all of you. However, with that comes, some difficulties every now and then.
Lindsay, I'm just trying to make sure I have controls. Dr. Mobley, I'm not going to be able to see the chat at all while presenting because of my screen setup, so I'll need your assistance.
Yep, I'll keep an eye on it. Try to enter as we go.
Do you guys just want to flash your camera on and say hey to the audience out there?
Sure, let me see if mine actually, I got it to work.
Glover?
See me? There we go.
Hey there. All right.
Okay. So this last section of the conference, we usually dedicated to some of the questions we receive every year, almost continuously from North Carolina public health professionals on the front line who are just trying to get the job done. So the way we've designed this, we have several case scenarios, and we will get feedback and input from Dr. Mobley and also Dr. Glover at relevant points. And we can answer the questions continuously along the way to the best of our abilities. There are a lot of people still here, and the chat can be sometimes a little challenging to manage. All right, so let's get going here. My screen has minimized to the point where I can't even see my slides. Let me fix that. Okay, here we go. All right. And I can barely see controls here, so just giving you all some clues that I can't really see much about what's going on out there. All right. Just rearranging so I can see everybody. Okay, so here we go. We have our panel. And here are disclosures. Most of them are mine in that I have participated in grants, research, contracts from a number of different companies and agencies. These are all paid to my employer. My employer completely manages my work. I would also like to acknowledge the contributions and the staff of the Prevention Training Center, including our administrative crew who've been there on the back end, Aisha Gentry, as well as Dr. Nick Van Wagner, who's my co-medical director, Jennifer Nell, who is our local North Carolina trainer, Dr. Arlene Senya, who is our local faculty member as well, and a few of our clinicians who have contributed to the content presenting here today, Tawana Hairston, Nicole Spencer, our North Carolina DPH staff, and our State Public Health Lab team. All right, let's get launching. All right, so we have our objectives listed here. We're going to try our best to review some of the North Carolina specific issues that we encounter and also talk about CDC prevention strategies that can help you out. We're going to be navigating through several cases. Should we run out of time, then we're going to skip and maybe get to the end. All right, here we go. Our first case. So we have a 28-year-old woman who comes in with reports of lesions that are there around the vaginal area. They were there 7 days before presentation. Interestingly, they denied rash, they denied lymphadenopathy, they denied ocular neuro symptoms. We're now going to march through those 5 Ps, which we heard about earlier on. And we found out there was 1 male sexual partner in the last 3 months. There was no substance use reported. In terms of past history of STIs, we found out that she was newly diagnosed with HIV, that there is not yet virologic control due to lack of engagement and care. And there's a remote history of treated syphilis. The last titer we have on file is 1 to 8. So before we go to our next question, Dr. Mobley, did you have any initial questions or comments about the case, things that providers might want to dive in a little bit deeper on here?
I don't, I mean, I might want to know when the date of that last titer, and then the date of the last sexual encounter, even though having 1 partner in the last 3 months, is that the same as if you last 6 months? Because I think, well, I won't spoil the stage here, but I think it would be relevant to know if there were more partners in the last 6 to 8 months. But I think you've got all the relevant information here.
Okay, great. And so that leads us to our next question. Is my slide advancing on the screen that you can see?
Not yet.
Let's see. We're having a clicking issue. Okay, there we go.
There you go.
This is our first question. If you can go ahead and drop some comments in the chat about what you think is going on.
You got a bunch of answers, so if you want to just go ahead.
All right. So the answer to this particular question, it seems like a lot of people were actually thinking about secondary syphilis, though I can't see the speed of scrolling is pretty fast there in the chat. But there are some other answers that are there that are worthwhile talking about. And just a reminder, it is really important for us to know a little bit more about what the current status is. And if you have access to point of care diagnostic, like an RPR that you can run on site, that's really going to help you try to understand a little bit better in terms of what's been going on. But we have a clinical finding here that we know is consistent with the secondary syphilis infection. As a reminder, these manifestations can be quite varied. It's one of the reasons why it's known as one of the great masquerader. In terms of the findings that we're seeing here, these are condyloma lata specifically, and we can also have other findings that can be present, including a diffuse rashing on the skin, and other constitutional symptoms can also be present. Just remember that you can have a number of lesions on other sites of the body that are worthwhile considering. And we'll see some pictures later on. And you can also have impressive alopecia associated with this stage of disease. So we have some lab results. We see that the RPR was non-reactive. Okay, I'm sure you all feel like that was not as expected. And we see that we have a T pallidum specific antibody that is reactive. So my next question for you, you can see that on the right side of the slide. Interested in your thoughts. So I'm seeing B and C, I see B and D, some C's. All right, we have a lot of thoughts here. Okay, so our answer for this question is, sorry, I'm having, my slides are not advancing as intended. There we go. All right. So, Dr. Mobley, the next slide is yours. Did you want to walk through this before I go to the next slide, or talk about it in the context of how the tests perform?
Up to you. I mean, I think I'm looking at some of the responses here, and I think a lot of people got both B and C. So yeah, the RPR being negative is a surprise, but it can happen, and we'll talk about why. And then, of course, secondary or early syphilis, which includes secondary, should be treated with benzathine penicillin G, 2.4 million units, IM times 1 dose. I did see several people who chose option D. And I just want to remind you, and we're going to go through this, that the treatment recommendations don't vary based on HIV status. So it's the same treatment for HIV positive and negative individuals. So the RPI being negative, so this is, it would be rare, right? So, you know, what we're talking about is prozone. So RPRs are non-treponemal specific antibody tests. They're detecting the cardiolipin that's released during an inflammatory response. That can include syphilis infection, but as we talked about earlier, it can be other things that result in this, right? So it's an inflammatory response that's being detected, not specifically an inflammatory response due to syphilis. And so when it's negative, with someone who's got classic signs or symptoms of primary or secondary syphilis, we always worry about prozone. I think last I've seen in the literature, roughly 2% of primary secondary cases, you may see prozone, the prozone phenomena in, and you can see here that it's when you have an excess concentration of antibodies. And so that prevents that formation of the precipitate, which is what we detect in the with the RPR test. And so if you see this patient, like this woman with very clear looking condyloma lata presentation and a negative RPR and a positive confirmatory test, it is worthwhile to ask your lab, and that, you know, it depends on which lab you're using, because some labs, as Dr. Glover will talk to you about, already do this. They already dilute enough that they're ruling out prozone, but some other labs, like commercial labs, they may not. And so you may want to either, when you're submitting the specimen, specifically note that you would like them to rule out prozone if the RPR comes back negative and the confirmatory is positive, by diluting the specimen and rerunning. And that's really important for commercial labs who only hold their test for a very limited amount of time. Like, for example, I think LabCorp only keeps the specimen for 7 days, whether it's positive or negative. So if you're calling day 9, that specimen might have already been discarded, and you would have to get the patient back in for a repeat test. I think that's the most relevant stuff on this slide. So you go to the next one.
Dr. Glover?
Yes. So at the laboratory, at the State Laboratory of Public Health, we perform in this case, we follow a algorithm. So the next slide, I'll get more into it, but we do the Ford algorithm, starting with the non-treponemal RPR. So here at our laboratory, we screen with the RPR, and so we do a titer and confirmatory if reactive for screening purposes. So all specimens that test reactive on the, all specimens testing reactive on the screening RPR automatically reflex to a quantitative RPR titer, and then followed by the syphilis confirmatory test, unless a previous positive for the syphilis confirmatory test or another confirmatory test result is on file for that particular patient. We also for the treponemal pallidum confirmatory serology test that we perform. We only if requesting follow-up confirmatory testing on a previous reactive screening test, and please provide screening test results such as quantitative titer results in those situations. Then lastly, we have an option where an RPR and a confirmatory test, even if the RPR is non-reactive. So as in this case, there's a situation where either in latent or late syphilis is suspected. We have the option where you can write the reason for testing on the other section. under the reason for testing. So you can write latent suspected or late syphilis suspected, or in this case, prozone, if prozone is suspected. In this case, we will perform an RPR and then a confirmatory test, even if the RPR is non-reactive. And as usual, if there's any questions, our staff are willing to, talk with you. Heather White is our supervisor of the laboratory, and she's a great resource for you if you have any questions, specific questions about our testing.
So, Dr. Glover, there's a question in the chat about that. Does dilution lengthen the result time? So if you have to dilute to rule out prozone, does that lengthen when the result ends up in sealer?
No. And we dilute, we dilute up to 1 to 256, which is the CDC recommendation for prozone. And then, so we dilute that and then we repeat the titer. And so I guess in this slide, this slide just kind of illustrates the two different testing algorithms for syphilis. So as I mentioned earlier, we do the traditional algorithm known as the forward algorithm that starts with the RPR. And then there's also the reverse algorithm that some laboratories may utilize. The reverse algorithm starts with a treponema-specific test. And I'll just say that the reverse algorithm kind of came from the fact that in high volume laboratories, or specifically starting with the blood banks, that's where they typically use this test. But after it got approval for more broad use beyond blood banks, it became very popular in commercial laboratories and other public health laboratories, or laboratories that felt they had high volume and that they could utilize the automated platforms to do the reverse algorithm. I'll just say now, with the forward algorithm, there are now automated tests that you can use to automate your RPRs. And so one of the things that we're looking for in our laboratory, which I know there are some laboratories in the state that also utilize, is to automate the RPR using a automated instrument and continue to do the traditional or forward algorithm. Okay, so where do you get your test results? So results can be accessed through the Clinical and Environmental Lab Results Portal, known as Sealer. So you can find, so there's different ways to access Sealer. So on our state lab homepage, under lab test results, that's one way you can get to the Sealer portal. There's another way. If you just do the search, you can see on the right-hand side, upper right-hand corner, there's this welcome. That's what the portal looks like. There's also a tutorial that's available on our webpage or our homepage for people who are new to Sealer or want to get access to it. You can call our customer service number at 919-733-3937, and they will help you get access to Sealer. If there's lockouts, that's also a resource as well.
It looks like we have a couple. Yeah.
Yeah, I was gonna capture some of the questions in here. How can I gain access?
Questions about EMRs and eTour. So I'll just say that you probably heard from our laboratory director about the process that we're undergoing to move to electronic test ordering and reporting. And so we are currently under, we're finishing the final phases of the testing of that, and we plan to have piloting occurring sometime in Q4 for basically initial rollout, which would be the Labor portal, and then followed by interface with the EMRs. So it's coming. Stay tuned.
There's a question about how to gain access to Sealer.
Oh, yeah. So you can go to our website, and on our website, there is, if you just click, there's a button that says access, request access, and you can fill out the paperwork and you can get access that way. Or if you have any questions, you can call our customer service number that's listed on the slide, and they will walk you through the process.
And then there's a question about, is Sealer for clinicians?
It is for clinicians or other healthcare providers that have been granted access within their institution.
There is another question, wondering if PCPs do this automatically and automatically test for TPPA, as so many FP antibodies.
Where
I'm not.
Where
do you see that one?
That? No. Oh wait.
It's at 303.
Do you think they're talking about FTABS, the actual?
I think so.
Oh.
Yeah.
Oh yeah, maybe they're talking about the mobilized.
So that brings up a good point. There are different types of confirmatory tests that are available. Dr. Glover mentioned the one that's specifically offered at the State Public Health Lab, but it's possible that you might have access to this elsewhere. I think we have a few health departments in the state of North Carolina that are actually running in-house confirmatory testing due to having that local expertise and support there. And you know, those tests, of course, they're actually different for the most part than what's running at the State Public Health Lab. But it's important to note that, you know, you do need your 2 tests in order to make your diagnosis of syphilis, and we need them. The tests have their different performance characteristics, and we didn't get into it here because it is incredibly detailed. But I do know that a lot of our ophthalmologists are a big fan of the FDABS test. So that's where we might sometimes see those orders being generated in systems where they can actually order, you know, a spectrum of different tests. So do you track that also? You know, with syphilis being a reportable disease, all places in the United States, the diagnosis of syphilis, including the laboratory results associated with that diagnosis, should be reported as well, regardless of which testing platform you used. I hope that answered the question for Jill. Anything else, Dr. Mobley, Dr. Glover?
I think someone asked something about the reverse algorithm.
Okay. So, sorry, my screen is a little wonky here.
We would have to go back. I mean, we don't, so I'll just say again, you know, we don't do the reverse algorithm here in at the state lab. There may be other laboratories in the state or commercial laboratories that run the reverse algorithm. But basically what you do is you start out with a treponema-specific test first. And then based on that result, if it's reactive, then they need to follow it up with a non-treponema-specific test, which would be the RPR or the VDRL. And then based on that, if that is discrepant, then they normally do. This is where the TPPA would come in to basically break the tie. That's basically how the reverse algorithm works.
And we do know that within certain districts, there are a variety of tests that are being used. So when you have a person that's being referred to your practice setting, it's really important to confirm not just a syphilis positive test, but what test was performed, so you can figure out what the next steps are. You know, definitely the reminder here is that with the reverse sequence, you still need that titer. You can't just stop at that first test. And as mentioned by our presenters earlier on, if you're running a rapid point of care test, which involves using your treponema component as your diagnostic tool, you need to get them to a setting where you can get your titer. And then about the people that are out there to help the cause. Dr. Mobley had mentioned earlier that we have the disease investigation team. They are your allies. They are there to help you with this particular component. I don't have a copy of the regional map, but I think if we can have somebody from our panel just drop it in there so they know who the people are in their neighborhood who are there to help. Also their local health departments or key resources. And as mentioned earlier on in Karen Hicks's slide, we also have the STD-CCN to be able to help, which also is technically the STI-CCN to get at the other comment from the viewer earlier on. And there's also, the state also has consultants that are available to help with staging a diagnosis, and then also to navigate the diagnostic challenge of syphilis, which is quite complex. All right. Anything else to add to that, Dr. Mobley, Dr. Glover?
I think you covered it.
And you can see mentioned here, this is a fabulous resource that's available that is actually very current, talking about the specific diagnostic component for syphilis. For the participant that had the question earlier on about the performance characteristics, I believe there's a table in there that gives you the details that you might be desiring. And this is a great resource to share as well. All right. Closing out this case, I just wanted to summarize the key facts here. Remembering that condyloma lata is a manifestation of secondary syphilis. Condylomas, they can present in a number of different places. They really need, they love mucosal surfaces, moist, warm areas, pretty much is where the person is having sex, where that can be a potential site of exposure. And so you want to keep a close eye out on that. Actually, recently we just saw a case, a provider mentioned a case where there was an interdigit lesion that was actually LADA. So, you know, as humans, sexual humans, you know, we do what works for us. And so keep that in mind. And that also is to remind everybody to make sure you're doing your full body skin examination as a part of your sexual health assessment. You can see mentioned here the comment on Prozone. You have the slide earlier with some details, remembering that we're going to use a stage-based approach regardless of what the person's HIV status is. And the frequency of follow-up for persons living with HIV is a little bit more frequent, but this might align also with routine care depending on what's going on with the person. And then I did want to put a plug in for the importance of making sure we have appropriate counseling on board, that we provide the educational tools they need in a manner that's acceptable to them and accessible, that we talked about making sure that people are linked into care if they're newly diagnosed with HIV, talking about harm reduction and STI prevention strategies such as DoxyPEP. And then we didn't get into it in too much detail, but also doing some counseling about the Jarisch-Hersheimer reaction, which can make people feel a bit unpleasant within the first 24 hours, fevers, chills, rigors, and sometimes a worsening of rash. This is not an allergy, and it's commonly something that we can see in people who have early syphilis when the treponeme count is pretty high. All right. This just summarizes that. I'm not going to go through it in much detail. This is available to you. And this gets to the comment about pregnancy and pregnant patients. And I know Dr. Mobley presented this data earlier on the conference, reinforcing the importance of getting people into care. We know that Bicillin is the only recommended treatment for pregnant patients. In this time of shortage, we need to navigate this very comfortably, and we'll present some resources for that later on. There's a very small window for gaps in terms of people who require a multi-dose regimen. And so we really need to work collaboratively as a team, because these are all prevention opportunities that we can work on. And then treatment in pregnancy, as Dr. Mobley mentioned, is based on the stage of disease. And extra shots of Bicillins don't help. And you want to get this all done greater than 30 days prior to delivery. Dr. Mobley, anything to add for that?
I don't think so.
Okay.
Good to go.
I see there's a comment that came into the chat about reviewing whether there's false testing. I think we got that already. Thank you for dropping in the regional map. And then also a plug-in for our nurses, our nurse-based team that's out there to support local health departments. Dr. Mobley, is there a map also for that one?
For what?
The regional
Sorry?
support for the technical assistance nursing?
Yes, I will find that map and put it in. Sorry, I'm answering questions, and I'll find the TATP map and put it in for those of you who don't already know how to contact your TATP nurse.
Awesome. And thank you all for dropping the questions in the chat continuously. We'll try to get through them as we're moving through it. All right, this is just a reminder about the serologic follow-up. It's there as a resource. We don't need to go into this right now because we got some more practice cases. All right, so our next case is a 35-year-old male, comes in, requests STI screening. They deny rash, lymphadenopathy, ocular, or neuro symptoms. In terms of the 5 Ps, they mentioned 2 partners in the last 3 months. In terms of practices, they mentioned they have 3 sites that are exposed during sex. They participate in receptive and insertive oral sex, penile anal sex, receptive anal sex. They don't report substance use. In terms of protection, they're not using condoms. They're not on DoxyPEP. It's unclear whether they know how to access those resources. The past history of STIs, there's a remote history of treated syphilis greater than a year ago. Last greater than 12 months. The RPR was 1-to-1. The TPPA was positive. There's no stageable finding on physical examination. So my next question is, what is the stage of disease? to the next slide. All right, so these are our results that are available to us. And what did we see there in terms of thoughts about the stage of disease? Let's see if anything went into the chat. Okay. All right.
Those are for whoever just asked about the slides. We'll make these available after this presentation. Because we had the answers in them, we didn't make them available beforehand to give you an opportunity to look at them and think about what you would choose as far as options, but we will certainly make them available after.
Okay. All right, and we see our test results that are available. Dr. Mobley, any comments about this one?
Let's see. Oh, we haven't gotten, okay.
We haven't gotten,
yep.
I'm going to advance the slide for you there.
Looking at the chat, it looks like most, actually I can't, too bad we didn't do a poll. I can't tell if the majority of folks there are a lot of answers in there, and I can't tell if the majority of folks chose late latent or late unknown duration as we call it now, but that is in fact correct. And
Dr. Mobley, see if you see it, the question
popped
now.
up. Yeah, there it is. We see
Oh,
it.
I do now. Thank you.
40%.
Yep. And yes, the majority of folks did get that right. So the treatment, so I think we're going to talk about the Bicillin recall and shortage in just a minute. So maybe I'll save my comments till then.
All right. Okay, but I do want to bring up something important because this has been a question that I have received. If you start a course with giving Bicillin, you cannot complete it with doxycycline. At least that's not recommended because there's actually no evidence-based data that that's an effective strategy. So I do not recommend that approach. And we'll talk about some ways to navigate things a little bit later on. But thank you for bringing that up. For this particular patient, I would just go ahead and just finish this course out with doxycycline. All right.
Yeah, and let me add on to that because I've had a number of clinicians who contacted me to ask that very question. And some of them have, are either ID trained or ID trained adjacent and feel comfortable doing, they got 1 or 2 doses of Bicillin, completing that course with 2 weeks of doxycycline instead of doing a full 28-day prescription. And what I would say for that is I would, like Dr. McNeil said, there is no data around that. But if you do that, and there are some patients where it makes sense for that, that, they either won't or can't tolerate a month of doxycycline, then I would be cautious to really make sure that's in patients where you're pretty confident they're going to follow up for their follow-up RPR, so you can assess whether or not they have that 4-fold drop. And also, I really would only do it in patients that have an RPR that's high enough that you expect to see a 4-fold drop. So someone who's coming in with a 1-to-1 or a 1-to-2, as you guys know, we oftentimes don't really see that drop that we expect because titers are so low to begin with. So really you don't have much to follow in those folks. But someone like this who has a 1-to-64 and most likely is an early syphilis case, even though we had to stage them as a late unknown duration. If you in fact have to do that kind of completion with less than 28 days of doxycycline, just make sure that they know how important it is for them to follow up for those RPR checks every 3, 6, or depending on their HIV status checkpoints.
Yeah. So yeah, a treatment is better than no treatment. So I think that's how I would summarize that part. And we definitely have had clients, if I think about a particular one, they had to leave the country. They got their Bicillin shot. They didn't complete their course, but they're going out and they intend to continue to be sexual. That makes sense. After they had completed treatment, of course. But then in that case, the safest deal was to be able to provide them with some coverage because we knew that they were going to continue to engage sexually. So they were given a course of doxycycline. So there is an individualized component that has to be provided in these cases. And definitely, having additional objective data that you can follow will help you be sure that everything's okay. And you probably want to make sure that you check in with them pretty frequently to make sure that the infection is cleared up. All right.
And I was going to add, even though the RPR, in this case, the RPR was positive for the latent syphilis, but if you had a scenario where it was negative and you suspected latent, this is one of those scenarios where on our form you would have marked the other and said you suspected latent syphilis, and then we would have performed the RPR and reflex for confirmatory testing, even if the RPR was negative. So this is another example.
And thank you for bringing that up, William, because that's another thing that we see being done in practice where people want both tests done. This is a prime example where you'd want to make sure that you marked it appropriately so we know what your needs are.
Yeah.
All right. Got another case here. So we have a 53-year-old male that's coming into ID clinic for evaluation of scrotal lesions. So I've already given you a location. So with this, you're gonna keep in mind this might be a little bit more complicated than the average case. We know that they are living with HIV, they are engaged in care, they have some comorbid conditions, including hypertension, 3 to 4 days after sexual activity, receptive oral sex, no condom use, they noticed this rash that was on their left scrotal area, and I'll show you some examples of that. They had some associated symptoms, which included a stinging sensation at the side of the lesions, tender lump in the inguinal area and swollen areas on the scrotum, and some fatigue. So I guess one of my first questions for you, what types of additional things would you like to know for this case? Any additional history questions? You feel you have enough information here?
Any ulcers, it says?
Yep. Any ulcers?
Are they on? So they're not on PrEP because they're HIV positive, unless you mean were they on PrEP before they were diagnosed, which I don't think we know. Are they taking HIV meds?
Mm-hmm. And then
discharge.
Yeah, and some great comments about what's going on with the skin, what they're doing, any topicals, any conditions that might predispose them to lesions, any fevers to suggest a systemic process, previous symptoms, what is the CD4 count? Yeah, okay.
You've got several people who have asked whether or not there's any discharge.
Whenever, if there's any discharge. Okay, great. All right, so this is the additional information that we have available to us. So in terms of the 5 Ps that are available, the patient reported that they had 1 male partner in the last 3 months and 2 in the last year. In terms of practices, they reported receptive and insertive oral sex, insertive and receptive anal sex with men only, and no substance use. In terms of protection, occasionally only with anal sex. And they do take doxy-pep, though inconsistently, and this is mainly because of a loss of resources that supported the ongoing prescription process. Past history of STIs, has had gonorrhea, has had chlamydia, so great candidate for doxy-pep, and had a history of syphilis that was remote. And all of the partners are male. So what are we thinking about here in terms of the differential diagnosis? And I promise you there are going to be some exam findings soon. Okay. So people are thinking herpes, a lot of herpes. And we have a little bit of a broader differential from one provider: herpes, syphilis, mpox, primary HSV. Okay. And then how would we approach this exam? What body parts are we going to look at? I do want to acknowledge that there is a need to talk about what prevention tools are available, and also maybe providing some resources for them. Okay. So we have a genital exam there, full body exam. Yeah. Entire body, everywhere. Okay. Yeah, we got it. All right. So this is your physical examination. So we see the vital signs. We have some vital signs here. And I did want to put in a comment here. The vital signs are a component of your 2808 form. This is the prime person for which this particular piece of data is incredibly useful. The blood pressure is 138/89. They have pulse rate of 90. They're not having a fever. They're breathing comfortably. They're a little anxious because there are some lesions that they are concerned about on their body. There are no scalp, oral, facial lesions noted. In terms of the lymph node examination, there's enlarged left inguinal node, and it's unilateral, so a unilateral enlargement of a lymph node. On the skin, there are just basically these rashes, these rash types that you can see here. Just more details as to what we're looking at. So in the GU area on the left side of the scrotum, there was a small, circumscribed lesion that was raised. It had an umbilicated appearance. There were two of them. There was a little bit of drainage coming from them. There was this black center that could be evaluated as well. There was some swelling surrounding both lesions. And in terms of the anorectal examination, external evaluation, there were no lesions, masses, condyloma, or tenderness. And I should mention that this particular provider does also have the capacity to do anoscopy examination, but there was no particular indication for this particular assessment. So what types of labs do we like to order? So these are our lesions. Are there any specific tests that come to mind? I see some people are thinking about Mpox. We have somebody who thinks about molluscum. They're wondering whether there might be a chancre somewhere. Some people want cultures. Cultures of what? Just to get an idea. All right, they want to involve the dermatologist. All right. Some people are interested in a TPPA. Just talking about the performance of tests here. A CBC, so thinking about more general management of this patient that's in here. Mpox, cultures of the pustule. Okay. Well, what about empiric regimens? So we're going to order some tests, but if you're in most practices, they don't have access to a point of care diagnostic like we do in local public health, like your rapid RPR. What types of tests do we want to order? And we have them listed here, but are there any empiric treatments you want to do while you're waiting for those results to come back? So somebody wants to screen for syphilis, gonorrhea, and chlamydia. And we have HSV already. Broad spectrum antibiotics. Okay. Angela, I'm going to need some guidance as to what you mean by that, because I'm an ID doctor. That could mean a number of things. Okay, isolate the patient until the results come back. Warm compresses. Okay, so we have a spectrum of answers, of approaches, I should say, listed here. There is a mention also of giving traditional STI management, such as Rosafen. Thank you for clarifying, Angela. So we're covering there for GC and that with that. Some pain management and a swab for orthopox. Okay. All right. So I think this is a good time point to talk about the differential. Just given the diversity of answers here, let's talk a little bit about what some of these rashes look like. So one of the ways that I like to simplify the process is to think about like what conditions could possibly be there in the differential. So when we think about conditions that might have a more broad presentation that are non-infectious, we'll start there. And that was, that great component of Dr. Edwards' talk earlier on, just knowing what normal is, and then also what non-infectious etiologies are out there that we need to be concerned about. Do any of these things fit? Are we dealing with recurrent aphthous stomatitis? We heard from Dr. Edwards that it's not something that she sees in terms of aphthous lesions in males in particular in her practice. Is this Behçet's? I think she gave us some really good guidance as to what some of those features are. Could it be trauma of some sort that this person is presenting with? Any concerns for cancer, anything that might be medication associated there on the skin? But then also keep in mind, we have syndromes that might present, and this person did not have any other specific syndromes that would suggest, there was no discharge that was mentioned specifically. We have lesions there. We know syphilis can look like a lot of things, so it's hard to tease that one out. But I did want to mention this whole thing about LGV, right? Because we did see somebody with a unilateral swelling, unilateral inguinal swelling, and is presenting with lesions that look kind of ulcerative. So that's something to keep in mind. when we're thinking about our diagnostics. And I did see somebody was ordering a chlamydia test, so that's good. That's going to help us figure this out, because I know that was a touch point that this provider thought about, like in their differential, could this be LGB that I'm seeing with this person coming in? And then as a side, while we're trying to make sure that we're getting things going, I did want to ask Dr. Glover, in terms of access to testing for chlamydia, gonorrhea, local health department, still the same process, no changes in how that's done, right?
That is correct.
Okay. All right. And then this is also a question that came up in terms of LGV specifically. Are there specific diagnostics that are available in the state of North Carolina that we could use to support this diagnosis? And the answer is no. And so here, because LGV is a serovar of chlamydia, we want to make sure we get that chlamydia test on board and to see if the clinical syndrome fits. And then we have the rashes that can cause these diffuse presentations, of which a lot of you smartly dropped here in the chat. I did not see zoster anywhere, I don't think, in the chat. There were a lot of things in there. I did see somebody mention molluscum, and people often forget that that's something that, skin to skin contact is all you need for that one. Mpox and pox viruses, that was mentioned in the chat. You can also consider whether there's other disseminated process or infection there, like gonorrhea, any fungal infections that might be there. But let's talk a little bit more about ulcerative diseases, because I know that's something that we're all concerned about. And in terms of ulcerative STIs, they can have a number of presentations, which can be quite challenging to interpret. The images we saw earlier on, they look at a lot of these images we see here, and you can see these are different disease entities. So we can see herpes virus, herpes presenting at the vermilion border, herpes on penis. You can see the difference here is we're seeing this erythematous base that's there, and you can see multiple clustered lesions. And then you saw the description that was provided earlier on about what an ulcerative lesion looks like by Dr. Edwards. We can also see with syphilis, you can have a chancre, and you see a chancre here on the mouth. That is a really firm indurated border you can see there. Looks a lot different than what we see here with herpes. And then also you can have multiple chancres presenting at the same time, and atypical presentation is also possible. Those are the other images we see there. LGV is what we were chatting about earlier on. When somebody has a unilateral swelling and an ulcer genital disease, it's something that's in your differential that's really important. And then we see chancroid and we see granuloma inguinale, and I'm going to mention these almost in the same breath, in that these are not things that we see commonly in practice. Dr. Mobley, do you know what the stats are for these in North Carolina? I know in the United States, we don't see very many of these cases at all.
Extremely low.
Yeah.
But if you want to know, you can use the interactive data dashboard to run it for your jurisdiction. But I think I looked at that last year, and I don't know that we had any. We had no confirmed, and even if they were probable, they didn't meet the case definition. So very, very, very few reported in the last 5 years at the very least.
We do sometimes see providers that come up with this in their differential, but we have confirmed cases are hard to come across. And thank you for mentioning the dashboard as well for that one. Okay. So then it gets us to syphilis, which, as you know, can mimic a number of different things. And I wanted to show you some varied presentations here. We saw some in our earlier cases as well. You can see nickel and dime type of presentation on skin, and I've picked various skin pigments so you can see how things can look differently. And here you can see diffuse, you can see lymphadenopathy. That's actually posterior auricular lymphadenopathy that I actually saw on a patient. It was quite impressive and present throughout the body. You can see that classically in a secondary stage syphilis. You can also have a diffuse rashing that we can see in that image next to that. You can also have very, more annular lesions on the genitals, like you can see there in that picture with the gloved hand. You can see perianal lesions in areas where you might shave, where it might be confusing as to what they are. So asking questions about sex is really important. You can also see a very nodular presentation there on the skin, on the hands, and then a classic palmar foot lesions there present on the skin in people with different pigments. But there are more images on syphilis, which I can get to right now, but it's just really important to know that there are various presentations. So then that gets us to the other things that we did not cover. So varicella, and that can also have more of a localized or generalized rash that's present. Molluscum, as you can see, with an umbilicated lesion, and the images we saw earlier did have those. Cryptococcus and disseminated cryptococcal disease can also show those as well. Mpox, which can look like some of the lesions we've seen before, as well as many of these other lesions here. And then you can also see the lesions of disseminated gonorrhea right there. And this is extremity findings that we saw on clinical exam on a patient that was seen for inpatient care. So a number of different presentations. So as to our case, so great thoughts, all of you. The comments you put in the chat were spot on. So laboratory results come back, and these are your findings. Okay, so I like that we thought about HSV. PCR test is available, State Public Health Lab, right, Dr. Glover?
That is correct.
Yeah, and I know you have a slide that's going to talk about this in more detail, so I will not pull you into this anymore. VZV is also an important test, as we talked about earlier on. That Mpox testing that you requested is detected in that we have the non-variola orthopox DNA virus detected. You did multi-site GCCT testing, which was totally appropriate in this instance, and also you did an RPR as well. So before we get in a little bit more on the details about how we get this testing done, what treatment or counseling do you want to provide? We'll talk about that. I want you to think about it a little bit. You can start to drop that in the chat. I'm going to let Dr. Glover talk a little bit about the local process for getting this testing done.
So Mpox testing at the State Lab of Public Health is performed by our BTEP unit, our Bioterrorism and Emerging Pathogens unit. And this test is a CDC test that relies on lesion swabs. And so the important thing with lesion swabs for testing at the state lab, because depending on the laboratory that you utilize, if you're utilizing a laboratory other than us, the collection recommendations may vary, and transport collections times may vary depending on that laboratory. But for us, we collect in duplicate. So the lesions are collected at the base in duplicate. These are dry swabs. That's very important. They're not placed into tubes with transport media, which you would normally do for other types of viruses such as HSV. So in this case, they're dry swabs. Each swab must be individually placed into its own tube that's properly labeled. You would utilize or submit the samples with our submission form, in this case, the BTEP submission form. So we have resources on our homepage that include a collection and shipping guidance document that will walk you through the 7 steps of how you need to submit a specimen to the state lab. Depending on whether it is clade 1 or suspected clade 1 or clade 2 Mpox, there are directions on how you need to package and ship that the specimen to the state lab. As I mentioned, there are Mpox guidance documents on our homepage. And then if there's any questions about submission guidance, collection of materials, we have a BTEP unit duty phone that's available 24/7, which is listed here, where you can call and get one of our BTEP unit personnel staff that will walk you through or answer any questions that you have. Also work with you to arrange a shipment and transport to the State Lab of Public Health.
Thank you. I do want to highlight a couple of the comments that I can see here. I'm glad that people are using the dashboard live time to follow up on that results. Great. So no LGV, no chancroid in the state of North Carolina. That definitely sounds about right. And then there's a comment here, Dr. Glover, about the STAT RPR process.
Yeah, I was about to type to it, but I can speak to it if you want me to. So basically what I'll just say is that turnaround times vary, depending on the laboratory that you're utilizing, depending on their testing volume, depending on the testing method. So I'll just say, stat testing is going to vary. Some laboratories don't offer stat testing. So in the state lab, we don't routinely offer stat testing. Stat testing is typically found in hospital laboratories due to the way they're staffed. So I can't speak to whether an hour is an appropriate length of time in terms of at a health department laboratory for stat testing. It's going to probably depend on a lot of factors in terms of the volume of that particular laboratory, and it may vary. Typically, laboratories track their turnaround times as a metric, and so I think, I'll just say if this was an issue or a situation, the state laboratory, we monitor our turnaround times for all of our tests on a quarterly basis with our quality assurance team, and we try to document reasons for the extended turnaround time if there is reasons, and then I'll just say for us, we're working on, for us, one of the things that we're working on is through electronic test ordering and reporting to try to get results out faster, because I think sometimes the results, depending on how the results are transmitted or provided back to providers, that can affect the turnaround time. So if you're doing paper or snail-based results versus electronic results, that can, but I will remind people that we have two ways in which you get results from the state lab. So one is through our sealer, which is electronic. But you also get, right now we still do paper in the mail, and sometimes people are waiting for that piece of paper, which is going to take longer than actually going into the sealer and actually looking at the electronic result, which you can also print out. So I think that's just an important reminder for people. So, yeah. Hopefully I answered that question.
Thank you, Dr. Glover. Dr. Mobley, I see that there's a comment here in the chat about the challenges with diagnosing chancroid, and that is correct. We have a component where in order to meet case definition, you have to, of course, not have any of the conditions that can mimic it. And from there, you go on to get specialized testing should there be a high suspicion for chancroid. So that is also part of the process. But if you also look nationally, we're seeing it's not a North Carolina specific thing. The trends are towards very low case counts. And just as a little bit of a joke, as I do work with some of the guidelines that are involving STI care. With one of our meetings, we actually chatted about whether we even need to talk about it in that forum, because there were hardly any cases for us to talk about. But we definitely do need to talk about it just in case it does appear, so providers are aware. But just wanted to mention that as an aside. Okay, so we have some comments that have popped in here about counseling messages and ways to talk to this person, just to make sure that they're taken care of in terms of their current condition, and then also their partners are taken care of as well. So in terms of how to counsel this particular patient, when the lab results are pending, there is still some fabulous guidance that's out there on the DHHS website that can help guide you through this. And you can see that what the providers need to know there in that box. Dr. Mobley, is there any specific information on the state site that you want to highlight related to MPOX right now currently?
No, I put the link there. We were updating it pretty frequently, and that might have dropped back a bit since the reported case counts have gone down, but that link has the most up-to-date information we have on both numbers as well as vaccination, where sites where you can find vaccine, which unfortunately now that they're not freely available, there may be limited sites where you can send your patients to get vaccine, but hopefully you can find someplace in your jurisdiction.
Yeah. And then as an important note in talking about vaccines, for this particular person, the presence of MPOX, they would not be a candidate to complete a vaccination series if they started it. And vaccination would not be recommended in this to support this primary event. But there may be partners in their network who would benefit from this. There are some great comments that are also in here about treatments that one might administer. And I see there's a question, are they eligible for TPOXX? Other supportive care. So supportive care is going to be the mainstay of what you do for somebody who has MPOX, and that would be supporting pain management, because we know the lesions can be quite painful, and depending on where they're located, there can be a diminished quality of life associated with them. And so we would encourage them to, present for medical care if those things could not be managed with the supportive care that they were providing at home. And there's still some guidance that's out there and resources available for that. And some of that information may possibly be in that link versus the CDC link, which still has some active components for that information. I do want to comment on this issue of TPOS because I feel this is something that often comes up. And with the recent cases we've seen where I have been one of the providers in contact with that team, you know, just for them to be aware that we now have data that's showing that TPOXX as a regimen is not found to be effective for the purposes of, you know, making that infection go away sooner. And so that data was published relatively recently. We can drop that information in the chat so that there is awareness as well for you all out there. So supportive care, and there are a number of things that we can support care here that's compassionate and aligning with what we do for persons with MPOX. And then I did see somebody mentioned, there was mention of isolation earlier on, I think, as well. And you should keep in mind that these lesions will run their course. And this course is going to involve a change going from macules, the full development of lesions, to crusting, and then that healed part. And when they are healed, scabs have dropped off, and you know, things have cleaned up really nicely on that case in terms of the surface of the lesions. That's when things are no longer infectious. There's a question asking about what is TPOXX. So tecovirimat is the name of the.
Go ahead.
Yeah, tecovirimat is the name. Dr. Mobley, can you drop the information?
I did. I just put the link to the CDC site, which will tell you what TPOXX is and also the current recommendations for when and when you might consider using it, which certainly have changed since the initial outbreak.
Yeah. So there are other supportive antivirals that might be used in severe cases, and even things to support the immune system in recovering from an mpox infection that we've definitely used in practice for very severe cases. Oftentimes, you and local health departments are not going to be managing these things in isolation. This is when you are, going to be working collaboratively with your infectious disease teams, possibly dermatologists and other specialists, depending on the density of lesions and what is going on there. So, so thank you for actually, Kay Dixon Axon, for that clarification. I hope that that link provides the information you need. If not, I think there's an infographic that talks about the findings of the recent study that we can load in there that might be useful as well. Okay. So some key points, mpox can mimic a number of infections, both and also non-infectious conditions. Screen if you have compatible rashes available and STI syndromes in persons that are sexually active. Concurrent STIs are actually quite common and things that we need to account for and make sure that we screen multiple sites to assure that we get the appropriate treatment on board. The current mainstay of treatment is supportive care. Vaccination is an important preventative tool, and you'll see the guidelines on which groups could benefit from that. Some additional resources are listed here in these links. All right. So we have another case. So moving on to our next case, and again with this one, you can just start dropping your comments in the chat as I read through it. So we have a 66-year-old female who's coming in. They have a past medical history of diabetes, COPD, hypertension, hyperlipidemia, so a lot of metabolic and chronic medical conditions. Unclear if there's a penicillin allergy. It was mentioned somewhere in the record. And they mentioned that they had some knots in their vaginal area, their hair was thinning, and they had some generalized weakness. And this is the timeline of events. So you're seeing them in the springtime, but there's this whole history of multiple contacts with medical care, which have included a visit for lesions, which a lot of people thought were bed bugs, a visit where there was some concern about a complicated migraine, and then another visit where there was concern about cellulitis in the perineal area. So what additional questions do you have here for this particular client that's in your care? And I should say this is somebody who's showing up to an STI clinic, not a linked academic medical center. History of syphilis, recent sexual partners, testing that's been done, sexual history. What are the knots? That was a great question. All right, 5Ps, partners, how many? All right. Okay, so let's see what additional information we have here. So we got some 5Ps here, and I should say at this visit, the client is also presenting with their adult child just to help navigate the process because it's become quite challenging, and they're also very frustrated because they've had so many medical visits. So in terms of partners, they mentioned one male partner contact in the fall. So that was like the missing gap here, and I'm glad that y'all all brought that up, even though we have an older person, as we heard from our earlier speaker, Dr. Dollar, we got to ask about sex. And so, new partner, and during that encounter, there were sometime later, there was some vaginal symptoms that started, and testing was performed appropriately for a number of conditions, which included T. vaginalis. With that initial encounter, actually, there was at some point an RPR that was drawn. I don't know if that helps with your differential. And that RPR was non-reactive. There were other STIs in the past. There were multiple tests that were done which showed T. vaginalis. They are currently not able to have children. They had a hysterectomy, so this part is not relevant. All right. So in terms of the exam, I'm assuming that we're going to go head to toe. And I see there's a question here about diabetes control. Their diabetes control was actually poor for this particular person. They had a significantly elevated A1C. Wondering why the NPs and MDs evaluating lesions, ERNs, can see mpox patients during the epidemic. So we'll talk about that a little bit more. Could the bed bug rash be syphilis? That is a great question. Okay. All right. So let's move on here. So these are your exam findings. We got some normal vital signs here. Blood pressure is slightly elevated. We know they have a history of hypertension. There is some alopecia that's actually quite impressive. The whole lower portion of the scalp, it almost looks like it's a hairstyle where the hair is missing in patches. There are hyperpigmented macules that can be seen on the chest, the back, the abdomen area. There's a palmar plantar rash. There are no discrete lesions on the anogenital area. There's nothing that can be found there, but I think that y'all will agree that the findings here are still very concerning. What types of tests do we want to order? And we're moving along in this case. Thank you for putting those comments in there. So I see RPR, HIV testing. They want to know a little bit about the partner history. There's concern about whether there might be secondary syphilis, whether there might be neurosyphilis. Okay. Okay, so we have another RPR that we're going to get. So let's see what our results are. Those are all excellent comments. So the RPR was reactive at 1 to 32. The TPPA is pending. We're getting some additional bacterial STI screening and HIV testing, great idea. Hep B, Hep C testing was also ordered as well. What are the next steps? So I did see a number of you were concerned about, there was mention here about reverse algorithm. Okay, we're getting some testing done. So in terms of what the next steps are, I saw that some people put they were concerned about neurosyphilis. So tools that are available to help us navigate this. This is an excellent tool that's out there from King County. It really walks you through thinking about what's going on with the patient to make sure that you get them linked to the appropriate care. In this case, in reviewing this person had some ocular symptoms, and any guess to ocular symptom here, you'll see refer to ophthalmology. All right. And then also this history was very complex. This person ultimately went on to receive higher care. So moving from a clinic setting into a setting where they can get help. And another tool that's really important to review is a brief neurologic examination. And I think you'll see that components of this are referenced in the 2808 as well, in terms of making sure there aren't any acute neurologic findings. And then this tool, just to remind you about the steps to walk through. This person, there were no findings there. Reminder about the stages. In the interest of time, I'm going to skip this one. So does this person need a lumbar puncture? No. Okay.
All right. I am so proud of all the no's I see in here. Okay. So, as mentioned by all of you, we have no focal findings here on neurologic examination. We only have known ocular findings here. So our diagnosis, just tools to help you along the way. If you're thinking about lumbar puncture, the guidelines updated give you some really distinct scenarios to consider where you'll do lumbar puncture. For this particular person, they don't meet that particular criteria. You can see them listed here, and this is here for you also as a reference. And if you have some time, Hamel et al. Is a great read from CID. They go through syphilis and really give it to you at a high level that you can use to navigate some of these complicated cases. Okay, so I'm just going to go ahead and so I see a comment in here about not seeing the polling. That's because we're actually answering the questions live in the chat. So keep on doing what you're doing, Lisa Britt. Okay, so in terms of our diagnosis, I think y'all have alluded to what's going on here. And some people are just saying we got D, but remember I commented on our screen, we also had some ocular symptoms going on there too. So we know we need some help to make that diagnosis in local health departments. We need our ophthalmologists. So our diagnosis is ocular syphilis with secondary syphilis. Just a case outcome here in terms of this, we made sure the person was treated effectively. They got the care they needed by ophthalmology. Neurology agreed with you. They did not need a lumbar puncture, and they got their IV penicillin. There was no penicillin allergy in this particular case. Okay.
Let me make just one point about that, Candice.
Sure.
So the treatment, I mean, outside of Bicillin shortage right now, this person, if they had secondary with ocular, so they needed IV penicillin for 10 to 14 days for the ocular infection. But for them, because they had secondary symptoms, you still want to give them Bicillin, the 2.4 million units. Again, outside of a shortage, I recognize that in a shortage, we might just say, give them 14 days of IV penicillin, which will cover both the secondary and the ocular infection. But in times of where we freely have Bicillin available, giving them that Bicillin renders them non-infectious faster. So, so you don't want to send someone who has active secondary symptoms out with just IV penicillin, because although ultimately at the end of their course, it would treat their secondary, you really want to get them to a point where they're non-infectious as fast as possible so that they don't transmit that infection.
Yeah, and that was a great point. In this particular case, there was some question about penicillin allergy. That the local health department provider was not able to administer it on site because that needed to be vetted further. And that turned out to not be an issue.
There's another, you see the question from Jessica here about if they were allergic, would they need to be desensitized and then treated? Do you want to go, you want to take it?
Yep, we can just do this next one, which I think it touches on this. That is an excellent question. In the interest of time, we're going to speed through this case at record-breaking speed. So we have a 24-year-old is coming in there. There are ulcerations that are present on the labia. As you can see, they report they had one sexual partner in the last month. They're having penile vaginal sex, oral vaginal sex with one partner, no substance use. They've had a history of cervicitis in the past, of the nature of which we don't know details. And they are pregnant. They are in their 4th month of pregnancy. They are not yet linked to prenatal care. So we have a lot of things that we can do in this visit to help out, right? So what is the stage of syphilis that we're seeing here? All right, great, you got it. All right, so we have an RPR, those 1 to 16. The person reports a penicillin allergy. What are our next steps needed here for management? All right, IC refer for desensitization. Do we want to know a little bit about what this allergy is? Okay, we also want to get them linked into care. Okay, so I want to give you a tool here that can be useful, the PenFast tool, which I think we might have talked about in some forums before, but it's a really useful tool that'll help you walk through the steps here, like so that you can try to figure out whether it's a true allergy or not. So I will allow you to, you can look at this in your own time. We will make sure you have this information available to you. And this gets us to the Bicillin recall and shortage as we're trying to navigate this case, right? We still need to know a little bit more about what's going on with this client, but while we're thinking through the next steps in terms of getting them potentially, desensitized, Dr. Mobley, did you want to give the high-level points on this?
Yeah, so hopefully you've all heard about the Bicillin recall. The lots that are recalled are here on the right. And the takeaway is the recall impacted a large portion of the Bicillin supply, which is only produced by one company, Pfizer. Right now, if you need Bicillin and you don't have it, so if you have a patient who absolutely has to be treated with Bicillin, then you can use the Bicillin medical request form that's on the right underneath the recalled lots table. You have to submit it for each individual patient. They don't ask for identifiers, but they do ask for justification of why you need it. And really what they're approving right now is pregnant women. So there might be a few others that they approve as well, but you have to fill it out for each individual patient you need it for, and then they'll overnight you the Bicillin. And that's just until the current stock they have is gone, unfortunately. And then there's also alternative regimens. So there's extensilin and lentisilin, both of which have been approved by the FDA for temporary importation into the US. So they're produced in other countries. One is France, the other might be Brazil. I can't remember where lentisilin comes from. So they're approved for importation into the US during times of shortage. I have heard that they can be quite expensive. And so I think that's prohibited a lot of folks from, particularly local health departments, from purchasing them. But those are two alternatives. If you can purchase them, they can be used in the same way that Bicillin is used. And then obviously you want to make sure that if you have Bicillin on hand, you hold that for pregnant women. Really try to use doxycycline for anyone who is eligible to get doxycycline for syphilis treatment, and keep your Bicillin on hand for pregnant women that need it, since that penicillin G is really the only proven antibiotic for the prevention and treatment of congenital syphilis.
Thank you. And I think you answered the question earlier on, can these two formulations be used to give to pregnant women? Did you want to throw in?
Yes,
yeah.
You can. Yes, you can use them for treatment in pregnant women. The other countries certainly do, and they have a lot of data. Here's the one caveat, which I have not found a way to get around, which is the FDA approved their importation into the US for use, where you would normally use Bicillin. But the FDA, because they didn't go through the drug approval process the way the FDA normally does, they have not certified the safety of the drugs. Now, the other countries have been using this forever, for as long as probably we've been using Bicillin, and they have a lot of safety data. But if you're using it here in the US, it doesn't have that, that check mark FDA has, or, has certified that this is safe for use in, in individuals. And that might impact insurance reimbursement, particularly if there is adverse drug reaction. So I would I don't think that's a reason not to use it if you can get it and you have a pregnant woman, because obviously the goal is to prevent congenital syphilis. But you might want to touch base with your insurers to see where they are related to coverage, one, to reimbursement for use of those two drugs, and also any coverage of adverse drug reactions, which we know are just a normal part of giving anyone an antimicrobial. It can happen to anyone at any time. So.
All right. Thank you, Dr. Mobley, for sharing that information. And it's a good thing we vetted what this allergy looked like, because in this particular case, their allergy reported when probed was nausea. So this actually was not a true allergy. And we were able to get them effective treatment in collaboration with another local health department that had Bicillin on hand. And remember, this person needs linkage to care, because it takes a team to make sure that the mom and the baby, make it through this whole process while trying to avoid congenital syphilis and ongoing syphilis for the mom and her partners. So this summarizes things. We don't need to go through this. We did this before. Some more things on staging and titers, and then summary for the case, just keeping in mind the things that Dr. Mobley mentioned earlier on about our cases of congenital syphilis in North Carolina, making sure we have people linked into appropriate care for serologic monitoring and clinical monitoring, just to make sure everybody does well in this whole process. Okay, so this is a really quick one. So Dr. Glover, what do you want to do here? Do you want to just skip to the last part talking about the algorithm?
Sure.
Okay. So this is a 30-year-old that's coming in here for screening. They have a partner who's expecting, who's just entering into prenatal care. He's trying to do his part by making sure he gets all his testing done. He gets a point of care RPR, a point of care, sorry, HIV test is performed, and it is reactive. All right. So what are your thoughts? I hope you're thinking about making sure we get this confirmed or not before we have a conversation. All right. So Dr. Glover, do you want to quickly walk through this algorithm?
Sure. So I'll just say we follow, at the State Laboratory of Public Health, we follow the CDC algorithm for HIV testing. So first of all, we perform the testing on serum. So our initial screening assay is done on the Abbott Alinity, and this is the HIV P24 antigen, and antibodies to HIV type 1 and type 2. We then follow that with the differentiation assay, which is the Bio-Rad Genius for HIV-1, HIV-2 antibodies. And then if necessary, then we also would reflex to the HIV-1 NAT or RNA done on the Hologic Panther. I just would like to point out that we have several send-out tests that we do because typically we perform testing on patients who are greater than or equal to 2 years of age. So other populations, such as people between the ages of up less than 2, we would send out to LabCorp. We also do prenatal testing is sent to Wadsworth. And then we also have availability to send samples to CDC. We've had several cases if they're suspected. We don't routinely test patients who are on PrEP because we don't have a specific panel right now that is specific for patients on PrEP. However, if we have circumstances where a patient may be tested through our algorithm that may be on PrEP, then we have, and you suspect, if there's the results look suspicious, we can have a consultation and send that sample to CDC, who has the ability to do Western blot testing to help try to alleviate or try to resolve certain discrepancies that may be from the test results.
All right, so we need to get some more information to try to understand what's going on in terms of risk factors and exposures. And you can see some suggested ones here. Any current symptoms suggest acute HIV, any risk factors for HIV, any recent HIV post-exposure prophylaxis, any recent HIV PrEP. And then Dr. Glover.
Sorry.
That's okay.
So basically in this case, so let's see. So HIV antibody immunoassay was positive, and then, let's see, it was, so the next step where you need to go on, you need to confirm all results with a differentiation test. So that would be the Genius.
All right, keep calm and carry on. So.
Yep. I think that's an important factor is to make sure that, if you have so I'll just say all reactive tests are repeated, and only repeatedly reactive tests are then, go on to the next test, which would be the differentiation test. And then if there is any suspicious or if the results are not confirmatory on the differentiation test, then you go on to a NAT or RNA. So I think that's just important. I think sometimes we receive questions about people concerned about the antigen antibody test being negative, and then their differentiation. There's a discrepancy between the tests, and I think it's important that we run through the algorithm. And if you suspect your patient has, if your patient's on PrEP, then we may need to do a consultation and do further testing. But I think that's important.
So to close out this case, when we ran through the test, this person had a negative test. So, we hadn't made it far enough through the algorithm here. So thank you, Dr. Glover, for walking us through that process. I know this is a question that the state lab is commonly consulted on, and then when we see in practice as more people are using point of care technology as well. Okay, so we have our last case. And this is more of a visual cue here for us to be aware of this process that's going on right now. So this one, we have a 30-year-old person that's coming in. They have an itchy red rash on the genitals, buttocks, thighs, and lower extremities. It looks a little bit like the image we see right here. And they have done some extensive traveling, as you can see highlighted. The rash is scaly, it's erythematous, it has an annular shape to it, or circular shape. You can see the distribution. They are sexually active, and they also do some genital grooming as well in terms of hair removal with waxing and shaving. They take HIV for, they take PrEP for HIV prevention. So in terms of treatment, they get, somebody was concerned about the possibility of this being some type of fungal skin infection, and they gave them fluconazole, which didn't make any headway in terms of progress. So anybody have an idea as to what this could be? I see some mention of ringworm, C. auris, so you're thinking exotic here. And what else? Anything you can think of? LGV, staph. Okay, somebody wants to use a topical antifungal. Okay. All right. So in terms of what this case is, in terms of diagnostics, a KOH PrEP was performed, which was positive for fungal elements. And this was actually a trichophyton case. And this is one of those emerging pathogens that we really need to be aware of because this particular variety we are seeing in sexually active persons. We've actually had some cases in the United States as well. How many of you have heard of something like this? Okay. All right. Not very common. All right. There was also information on this was also recently sent out to some of the listservs. Dr. Mobley, where was it distributed?
You mean where did I distribute it?
Yes.
Oh, I sent it to the local health department medical director listserv. In hindsight, I probably should have sent it to the STD enhanced registered rural nurse listserv and the communicable disease nurse listserv. So I can do that. I will. You guys will see it either today or tomorrow, coming to you.
All right. So just information as we, I see somebody dropped in the chat, they were seeing more concerns about this in the Northeast, and that is correct. The first case was actually seen in New York. And these cases have been circulating already in Europe and has been formally identified. Sexual contact and co-concurrence of STIs is quite common. These lesions can be quite painful and uncomfortable, and they are hard to manage. This is one where we need to use a team approach. Our dermatologists are key to helping us out with this because one of the diagnostics is going to be a KOH PrEP. Though in STI care, we do a lot of KOH PrEPs of vaginal secretions. We often, I don't think there are many of us that do this on skin areas. That said, the actual memo includes a video that's really cool to train. Though in speaking to some of my dermatology colleagues, they're saying the video is very good, but it's probably not as simple as that. So this is definitely a team effort that's going to help us out here. You can see some details here. There's actually a provider registry that's already started. And this is being run out of University of Alabama. When you get the information from Dr. Mobley, you'll also see that attachment there about the registry. So these are just some important things I want you to be aware of regarding this particular infection. Dr. Mobley, anything else? I think we talked about like whether resources could be used to support the funding,
right,
treatment, and that might be an ongoing conversation.
Yeah. So because if you see this and you're seeing it in an STI clinic, it can be sexually transmitted. You can use your 340B as the state funds to purchase the antifungal to treat this. I will say that I believe it's pretty expensive, but I wonder if the 340B pricing, particularly through Cardinal, would make it affordable, particularly since you don't expect to see high numbers of individuals with this. But I do, if you have this come up and you want to have terbinafine on hand to treat potential cases, let me know and I can pull in our state pharmacist and make sure that we're not going to get in 340B trouble using the state funds to purchase it.
Thank you, Dr. Mobley. And I see some other comments in the chat. I'm thinking maybe at some point we can also talk about ways that local health departments and regular providers might be able to help with the diagnostics here in a little bit more detail. It's probably beyond the scope of what we can do right now. The question, why didn't diflucan help or fluconazole? So this is a This is a dermatosis. This particular variety of infection is not really as responsive to fluconazole as a topical or an oral. And so it's something to keep in mind. It might be one of your clues, right? It looks like it could be ringworm, right? But it is in somebody who's sexually active on the genitals. Then you might want to think, if you're not having responsiveness, could this be something else? And then just to bring to light that there are a number of infections in the STI world and also in the regular infection world that we use fluconazole for that go beyond just Candida. This one is a pretty hardy one, and so we need to pull out a very strong antifungal regimen, and that's going to be terbinafine, which is not commonly available in practice and does require some monitoring by the prescribing provider. Okay, so that's all we got for today. I would like to thank you all for taking the time to be able to talk about these really important conversations. I hope that we will be able to continue this conversation in a later date. Please continue to drop your questions in the chat, and we'll see what we can do in terms of sharing information on the questions that we have left unanswered today. There are a number of resources that are available in the community, including the National STI Curriculum, also the CCN site, which helps you to field complicated questions. The state also has a great resource for helping you field complicated questions as well. In terms of announcements, I will now turn it over to Lindsay, but before I do that, I'd like to thank our panelists who have contributed their time, their effort to this this whole update today, in sharing this information. I know this is not an easy time to show up and get this work done, and I'm glad that we all took the time to be here today. To our participants for showing up, for being engaging, for dropping in the chat, for showing that you care, which means that you're here today. I'd like to thank you all for that. And for our administrative team on the training center side, on the state side, and also with Lindsay's team at Northwest AHEC, thank you for another fabulous conference. We really enjoyed this time working with you as well. Lindsay?